acute demyelinating disorders in children.
Good morning, and thank you very much for inviting me to talk to you today on deciphering pediatric neuroinflammatory disorders. I'm very sorry not to be there in person, but hope that over the next 25 minutes in this virtual talk, I can help bring some guidance on management of these challenging conditions. Here are my disclosures. And of importance to note is in this talk, I may refer to medicines which are not licensed for specific use in pediatric populations in your country. So in adults, the first episode of demyelination is almost always the start of multiple sclerosis. But in pediatrics, multiple sclerosis is just one of a number of potentially relapsing neuroinflammatory conditions. As these conditions all have different underlying pathophysiology, making an accurate diagnosis is essential for us to be able to provide the correct treatment. When a pediatrician meets a child for the first time who is unwell with an episode of demyelination, they have to decide whether this is likely to be the first onset of a presentation of MOGAD, which stands for myelin oligodendrocyte glycoprotein antibody demyelination, which accounts for around 50 to 60% of all first acquired demyelinating syndromes. And importantly, it is likely to be a monophasic disorder, i.e. that is not relapsing, because around 60 to 70% of patients with their first episode do not relapse. And it is typically in a younger child, often presenting with encephalopathy, with imaging changes shown, as you can see here on my pointer, of fluffy, poorly demarcated T2 lesions, often in the brainstem. The second thing the clinician has to decide, is it likely to be the first presentation of a relapsing disorder, such as relapsing remitting multiple sclerosis, with ongoing frequent relapses. And if you compare the two MRI images here, you can see how different the lesions look, with the MS lesions in contrast showing well-circumscribed ovoid lesions in a very specific distribution, typically these juxtacortical or periventricular or deep white matter. Or whether the lesions are found in a very specific area, such as the optic nerve and the longitudinally extensive transverse myelitis, where we see with another relapsing disorder, which is less frequently relapsing than relapsing remitting MS, and that is aquaporin 4 antibody-mediated NMOSD. And these have two very specific topographies. And again, it's very important for us to consider treatment in these patients. And it's important for us to use both the MRI patterns as well as other biomarkers to take into account what diagnosis we're going to give these young people, such as the presence or absence of oligoclonal bands being produced intrathecally, and we look for these in the cerebrospinal fluid, and they are found in the majority of young people with active relapsing remitting multiple sclerosis, but only in a very small percentage of patients with MOGAD. As well as looking in the serum for antibodies such as aquaporin 4, or of course, MOGAD antibodies, which we know can have a very similar presentation with optic nerve involvement and again a longitudinally extensive transverse myelitis, but actually can have a very different pathogenesis and therefore has different treatments and outcomes. And finally, it is difficult for some of these conditions, such as MOGAD, to predict whether they actually are going to be monophasic at outset. And there can be very long disease latencies between attacks, such as has been reported for an episode of ADEM, followed sometimes 20, 30 years later by an episode of optic neuritis, such as we see with ADEM on. And we are now picking up adults who have optic neuritis who report an episode of acute disseminated encephalomyelitis as a child. So overall, acute demyelinating syndromes in pediatrics are rare. And in 2010, we undertook a surveillance study over 12 months across the United Kingdom of all acute demyelinating syndromes. And we found 125 cases, which gave us an overall incidence of about 1 in 100,000 children under 16 years of age. And this figure was roughly comparable to that seen in other northern sites such as France and Canada. And in 2020, we completed a follow-up study and identified that, unlike in adults, 70% of these patients were monophasic. That is, they didn't have any further relapses when we were looking after them. We don't, unfortunately, have serum for all of them, but in those we tested, we assumed that around 40 to 50% of them would have had MOG antibody positivity. And in those cases where there was relapsing demyelination, so the 30%, of those, by far the majority were multiple sclerosis, 2/3 of those who were relapsing. It was far less frequent to have relapsing MOGAD, only 4% of the patients, and aquaporin 4 antibody-mediated disorders was very rare at 1.6%, which put our incidence at about 1 in 5 million. And really importantly to note is that this group here, 4% of the patients, even with expert opinion, were actually misdiagnosed. And it's really important for us to consider all the different conditions that can present similarly. And when we see a list like this of all the differential diagnoses, it just makes our hearts sink. So it's really important to be aware of the red flags. And for me, in pediatrics, that is a young patient, less than 2 years of age, presenting with a history that sounds slightly atypical, or where there's a preceding history of developmental delay. If there's systemic and constitutional symptoms, such as unrelated temperatures, mouth ulcers, a funny rash, where there's gradual onset over weeks rather than hours to days, because we know demyelination comes on quickly. If there are neurological symptoms and signs outside the central nervous system, such as a myopathy or a neuropathy, as well as the central signs, or if the MRI findings are atypical with persistent enhancement seen, or significant hemorrhage into the lesion, or longitudinally extensive long cord lesions. I'd now like to go through a few cases as an example, and the first case I'd like to look at is that of a 4-year-old girl who presented to us with left-sided weakness, no encephalopathy. She had evidence of being Epstein-Barr virus IgG positive, which showed that she had had remote infection in the past, and her oligoclonal bands were positive in the CSF, and she was vitamin D deficient. And all 3 of these markers we know put her at high risk of having relapsing remitting multiple sclerosis. And in addition, her aquaporin 4 and MOG antibodies were both negative in the serum. And our MRI showed us the typical changes which I've highlighted previously that we associate with multiple sclerosis. Again, you can see the well-circumscribed ovoid lesions that are periventricular, juxtacortical, deep white, as well as some infratentorial. And you can see here the typical C-shaped contrast-enhancing ring, and possibly a central vein sign on the right here. And based on this, using the 2017 McDonald diagnostic criteria of having contrast-enhancing lesions as well as non-contrasting lesions and band positivity, we were able to give her a diagnosis of having relapsing remitting multiple sclerosis despite only being 4 years of age. So, we know that pediatric MS can occur at any age, with children as young as 3 having been diagnosed with MS. And we can see from this Danish study that around 5 to 10% of MS patients present less than 18 years of age. And we know that from a population-based study in the UK, that Kathy Harding, from just over 2,000 adults, noted that 5.4% of people, which was 111 pediatric patients, had their onset under 11 years of age. But it's important to note that the majority of these patients had their onset in teenage years, with average age being 14.5 years. Only 0.3% of pediatric MS started less than 10 years of age. So do be cautious in making this diagnosis, as we recognize there are clear, well-defined phenotypes that are age-related. As I've highlighted, acute disseminated encephalomyelitis, or ADEM, is much more likely to be in the younger child, with MS much more likely to be there in the teenage years, and NMOSD can occur across the spectrum. So how do we diagnose MS? MS in pediatrics, as in adults, remains a clinical diagnosis. There are no specific biomarkers, and misdiagnosis, particularly in adults, is common. And there's this lovely paper from Andrew Solomon from the east coast of the United States. And he identified 110 patients who had been misdiagnosed for years. And 70% of these patients had actually been given disease-modifying treatment for their MS. And importantly, the mimics were not the really rare conditions that we worry about, but they were misdiagnosed because people didn't use the MS diagnostic criteria properly, because they looked at the MRIs and they saw little white matter lesions, such as we can sometimes see in teenagers with migraine, and they gave them a diagnosis of multiple sclerosis. And this is what the McDonald criteria are all about. As you know, MRI imaging is crucial for diagnosis, and we all now use the McDonald criteria, and each time we can see, each reiteration that we've had, the aim of the McDonald criteria are to enable us to make a more accurate diagnosis more rapidly so we can start these patients on treatment. From 2010, pediatrics have been included in the diagnostic criteria. At that stage, they said children under 10 look slightly different from children over 10. But when we looked at the multiple sclerosis in our patient cohort of just over 100 patients with MS, we identified that children under 10 with MS and over 11 had the same baseline clinical, radiological, and oligoclonal band findings as children above 11. So what we concluded is that MS in childhood is the same, and regardless of age. And when you see in some of the older literature that pediatric onset MS looks different from adult onset MS, it's probably because it wasn't MS. And we know that there are well-recognized papers now where people had actually not diagnosed MOGAD, but had called it a relapsing MS, which looked different. So please just try and move on from that concept. In addition, the McDonald 2017 criteria had allowed us to use the CSF oligoclonal bands as evidence of dissemination in time. To diagnose MS, we need two criteria: dissemination in space, with the lesions disseminated in different areas or topographies of the brain, and dissemination in time, more than 30 days apart. And we could see that by using the McDonald 2017 criteria, this significantly improved our ability to make an accurate diagnosis, with 47% and around 46%, depending on age, going up to 83%. And we were expecting the McDonald 2024 criteria last year. They've been delayed, but we're hoping they'll be out slightly later this year. And we're expecting them to highlight that all children younger than 12 years of age should have MOG antibody excluded. And they're also going to talk reference to some of the more specific imaging criteria, such as slowly expanding lesions and paramagnetic rim lesions. And while you don't need to know the details about those, it is important to know there's a lot of work currently going on in pediatrics looking at the relevance of these criteria for pediatric MS. And we know from some lovely work and from Julia Fadder's group in Canada that actually looking at slowly expanding lesions, they can very successfully distinguish MS from MOGAD, with the majority of patients with MS having slowly expanding lesions and nothing seen in patients with MOGAD. The second illustrative case I'd like to do is that of an 11-year-old girl who was referred to us in June in 2017. She had had a history of, in November 2016, presenting with right optic neuritis. 2 months later, brainstem symptoms with dizziness, nausea, and vomiting. 3 months after that, she presented with bilateral leg weakness, and a month after that, right-armed weakness and paresthesia. Yet when you examined her, apart from a pale optic disc on the right from her very original optic neuritis and some brisk reflexes, she appeared very well. And I think this is a really important factor about pediatric onset MS. These children look really well. And as a result, it often lulls us into a false sense of security that this is not urgent. But actually, they are accumulating damage. So all children with a suspected demyelinating disorder should be referred urgently for expert assessment. We investigated her, confirmed that her oligoclonal bands were positive in the CSF. She was also JC virus antibody positive, which gave us an idea that certain treatments would not be good for her. As suspected, her MOG was negative and she was vitamin D deficient. And her MRI again showed us the typical changes which we associate with multiple sclerosis, typically around the vascular corpus callosum, periventricular, and you can see enhancement, as well as a spinal lesion, a small short spinal lesion in the cervical area, which highlights to us that she's high risk for progression. So we were able to give her a diagnosis of relapsing remitting MS. And the reason why I brought this case and highlighted that it is actually seen as an urgent referral that is needed is that children are more inflammatory than adults. And you see, even up to 6 years after their onset, this is the relapse rate in adults and this is the relapse rate in children, with children having 2 to 3 times the relapse rate that we see in adults. They also have significantly more brain lesion accumulation when we compare them to adults, and on the few post-mortem cases that we have, they are a lot more inflammatory. Adult treatments for MS are mainly based on anti-inflammatory side of MS, and there's been an explosion over 30 years of the different treatments that are available. However, it's really lagged behind in the pediatric aspect, with the first drug approved for pediatric MS in 2018, that being fingolimod. It was so successful that the trial was actually stopped early. Then there have been 2 subsequent trials, one for teriflunomide and another one for dimethyl fumarate. So currently there are only 3 drugs licensed. But actually, we are using in the developed world mainly a whole host of other adult-based in newer disease-modifying treatments. And in this lovely study from Crystal Crisco, where she looked at over 750 pediatric patients from the US network, she again showed a significant decrease. So this is the newer treatments, the highly effective treatments such as the CD20s, and this is the old platform therapies, the injectables. And here you can see the annualized relapse rate, how many relapses in a year you would anticipate. So actually using the newer treatment, you can see a significant decrease in the pediatric population for those on the newer treatment, as well as a significant decrease when comparing the number of new T2 lesions that have been, sorry, my pointer's on the wrong screen, this is the annualized relapse rate with the newer treatments and the older treatments, and this is the accumulation of T2 lesions on the newer treatments, significantly less than those on the older treatments. And that led my colleague, Yale Cohen, to write a lovely article on looking at what is first-line therapy in pediatrics and highlighting that probably we should not be using injectables or platform therapy anymore. And we should be going to the aggressive, highly effective treatments that we know are going to work very well for their anti-inflammatory component. And this has basically become our standard of care in Great Ormond Street. And year on year, we can see the significant increase since it's been licensed and available for use in our population of ocrelizumab use. And we have currently more than 66 pediatric onset MS patients who've been on treatment for more than 12 months that we are managing. And we've seen extremely successful changes from the introduction of this drug. We don't have a relapse clinic anymore, and we really are aiming for something called NEDA, which is no evidence of disease activity. And NEDA 3 means that there's no clinical relapses, there are no new lesions on the MRI, and no progression in their disability score. And while we saw 3 or 4 of the relapses were in the first 6 months, once we got on to the next 6 months, we just don't see patients having problems anymore. And this is very much was the same as it was confirmed from Brenda Banwell subsequently at ECTRIMS from the operetta data, which is the trial currently looking at ocrelizumab versus fingolimod, and it confirmed the excellent efficacy that we're seeing after about 12 weeks, with by 24 weeks of being on the drug, no significant side effects. And why do we want treatment to start so quickly? Because we know that actually this is the first patient. When a child presents with multiple sclerosis, they look very well, but because it's highly inflammatory, they continue to have multiple relapses, they accumulate more and more brain lesions, and over time, they get progressive brain atrophy. And while children do recover better, for every 10 years that they are younger, we can see that there's a significant improvement and a quicker improvement in their ability both physically as well as cognitively, we know that the long-term implications are quite significant. And from a large Italian study, here they looked at both the physical, the EDSS, Expanded Disability Status Score, which is a way of looking at how well an individual moved, and they looked at the children versus the adults, as well as the cognitive impairment. And we could see, even when taking into account for the age of onset, that children's with pediatric onset MS had much worse disability, both cognitive and physical outcomes over time. I'm now going to move away from multiple sclerosis and look at another demyelinating disorder. And the first case I'd like to present here is that of an 11-year-old girl who presented with a 3-week history of persistent retching and vomiting, so much so that she dropped her sodium down to 118. The gastrointestinal investigations were normal. You can see that her CT head was completely normal, and her vomiting over a couple of weeks resolved and she was discharged. But then she presented with an ascending weakness, leading over a week to quadriparesis. She was diagnosed as having a transverse myelitis. We can see here a longitudinal extensive transverse myelitis, some changes cerebrally, and she made a good recovery, and she was discharged home after about 10 days walking. But lo and behold, unfortunately, 3 months later, she re-presented, this time with a devastating high cervical injury. And she needed admission to the intensive care unit, and it actually took her 18 months to learn to walk again. And actually somebody looked back and realized that 3 months before, an aquaporin 4 antibody had been sent, but it never chased. And the reason why I brought this case for us to discuss is that it really illustrates missed opportunities for us to make the diagnosis. And if you look at the Wingerchuk criteria of how to diagnose neuromyelitis optica spectrum disorder, these were produced in 2015. That if you have the presence of aquaporin 4, you only need one additional episode, either an optic neuritis or an acute myelitis, or even just an area postrema syndrome. This comes from the brainstem, where it's our patient presenting with recurrent nausea, recurrent vomiting, or persistent hiccups, such as our patient did, where she had the persistent vomiting. So actually, it could have been picked up there, and she could have had both episodes of transverse myelitis prevented. The 2025 revised criteria for diagnosing NMOSD are due out later this year, so do keep an eye out for them, and hopefully I can update you on these next year. So what is aquaporin 4 mediated neuromyelitis optica spectrum disorder? Quite a mouthful. It's a chronic relapsing autoimmune disease, shortened to NMOSD, and it's mediated through B cells, which are producing the aquaporin 4 antibody. And these antibodies in turn go off and produce central nervous damage. And they produce them through promoting pro-inflammatory cytokines, particularly IL-6. They also cause complement activations, this is complement C5, C6, as well as direct antibody-mediated cytotoxicity. And understanding the pathogenesis has allowed us to direct some of the treatments towards all 3 of these pathways. And we now have 3 licensed treatments. We have satralizumab, which is an IL-6 receptor. We have eculizumab, which is a complement inhibitor, and inebilizumab, which is a CD2019 and 20 inhibitor. And these, unfortunately, have not been trialed as yet in pediatric patients. We currently are inclined to use rituximab, another CD20. As we know, we see quite significant benefits, even used as first line. We see a significant decrease in the annualized relapse rate. And we can see this decreasing from before treatment, after treatment, and even in those patients where we have started them on MMF or azathioprine, we can see significant benefits from escalating to a CD20. And the reason why it's important is that unlike MS, NMOSD does not have progression independent of relapse activity. With MS, we see a chronic degenerative form of the disease where patients accumulate disability even when they're not having relapses. Whereas in NMOSD, the disability is entirely relapse dependent. So if you can prevent the relapses with a disease-modifying treatment, you can prevent the accumulation of disability. So here's each relapse, you get a bit of disability, you have another relapse, you get a bit more disability, another relapses, more disability over time. And we know that without treatment, around 50% of patients will need a wheelchair within 5 years, and 62% are blind. So really, it's not a good condition to have, and it's really important for us to get on top of it quickly and aggressively. I'm now going to move on to the last part of my talk, and that is of a fourth case I'd like to present, is that of a 6-year-old girl who presented initially with bilateral optic neuritis, and you can see here on the imaging typical changes of bright enhanced T2 lesions of the optic nerve. And as predicted, for a young girl with a bilateral optic neuritis, we would, of course, immediately send the MOG antibody, and this came back as positive. We gave her a short course of intravenous steroids and then an 8-week oral prednisolone taper, as is our practice, reassured the parents that this was likely to be monophasic and didn't need any further treatment. However, she then went on to have a further episode with, again, this time with a left optic neuritis, and you're presenting with irritability, lethargy, and ataxia, and you can see that she had accumulated some new brainstem changes. And this enabled us to give her a revised diagnosis of multiphasic disseminated encephalomyelitis, which we know is almost always associated with MOGAD. We at the time started her on mycophenolate mofetil, because that is, while it's not our disease-modifying agent of choice, it's only one we're allowed to use. And we had her on that for a number of months. We know it takes about 3 to 6 months before it's completely effective. But 8 months later, she presented with a further episode, and you can see she's now accumulated new brainstem changes, and we were then able to add IVIG. And this is actually our disease-modifying treatment of choice. And on this, she remained relapse-free. So what is the best combination and what is the best treatment? We don't actually know. There are no studies at the moment of what is the best treatment for pediatric MOGAD. We know that the oral prednisolone taper for 6, 8, maybe 10 weeks, not longer, after the relapse of the initial presentation may decrease the risk of relapse. But we believe that the best treatment probably is giving regular IVIG, and we give our patients monthly, but we can only give it as third line. So many of our patients are on a combination of MMF and IVIG, and that seems to keep them well. So what I've shown to you is that a child with MOGAD can present with ADEM. As we've seen in the recent MOGAD diagnostic criteria, they commonly present with either an episode of ADEM or with optic neuritis. However, there are other situations. They can present with a single isolated optic neuritis, which is relapsing. They can present with a transverse myelitis or a combination of the two, which is MOGAD-associated NMOSD. Or there are other more unusual phenotypes, such as we see in the very young child with a leukodystrophy-like appearance in a child who's having ongoing relapses, or even a meningoencephalitis with quite significant flare lesions associated around the cortex, and these children present with seizures. And just to illustrate this is my final case, that of a 9-year-old boy who was admitted with a generalized tonic-clonic seizure, which was prolonged. He had a lumbar puncture, which revealed an opening pressure of above 30 centimeters of water. Normal is about 23, 24. Had some elevated white cell count and a marginally elevated protein. His EEG showed some focal slowing on the left side here, particularly around the front. This is the right side, which looked relatively normal. And when you see his imaging, it's not surprising why he might have presented with seizures and some focal slowing on his EEG. And we recognize this flare changes as possibly a result of a cortical encephalitis. Interestingly, this is his imaging 3 months later, and this is typical of what we see with MOGAD, in that there's complete resolution. And he had an episode of MOG antibody-associated encephalitis. So we recognize that MOG antibody, and we've recently published our experience, has shown that it's the most common cohort. 7% of all our MOGAD cases actually had encephalitis. And we looked at 235 children With MOGAD, 74 of them presented with ADEM, 33 of them with MOG antibody encephalitis. And the MOG antibody encephalitis typically presented there with a slightly older child. They presented with a history of headaches, with seizures, sometimes some difficulty walking, and ataxia and vomiting. A significant percentage of them needed intensive care, and not surprisingly, with a raised white cell count, raised protein, and a seizure, infective meningoencephalitis was the initial diagnosis in 67% of them. And the initial important take-home message is that the initial brain MRI was normal in 24%. Then we saw some abnormal imaging in the remainder with leptomeningeal enhancement. But if you're in ICU and the child gets an early scan, which is normal, and this picture doesn't fit, think about repeating the scan in 48 hours time, because we know that lesions are dynamic in MOGAD and can change quite significantly over sort of 24, 48, and 72 hours. And just like we can see the resolution at 3 months, it's this very typical hallmark really of MOGAD is the waxing and waning and disappearing lesions. So hopefully this has been important for you to learn something about demyelination and how to decipher the different antibodies and as well as the different presentations of demyelination. So really the take-home messages that I'd like you to consider is that MOG antibody is the commonest cause of demyelination in young children, and around 70% are monophasic. So for the first episode, you don't need to consider giving prophylactic treatment to prevent further relapses. You only need to treat after the second. Pediatric onset multiple sclerosis looks like adult onset MS with the small ovoid periventricular and juxtacortical lesions, but it is more inflammatory with significant long-term consequences, and providing highly effective treatment significantly improves the long-term outcome. Aquaporin 4 antibody-mediated demyelination presents similarly to adults. It is very rare, I said at 1 in 5 million in the UK, and diagnosis as a result is often delayed. But do think about it when you see children with recurrent vomiting or hiccups, or when you get a child with an optic neuritis, SLE with unusual symptoms, or an area postrema syndrome. And finally, with MOGAD, the commonest demyelination that we'll see, the phenotype is expanding. So do consider it in cases of meningoencephalitis, as well now as in presentations of raised intracranial pressure. Thank you very much for listening.
نشكر الدكتوره شيريل هيمنجواي على المحاضره القيمه دي، ونشكر الدكتوره مريان انها اتاحت لنا الفرصه ان احنا نسمع يعني من اقوى سنترز في العالم في البيدياتريك نيرولوجي، سنتر بتاع جريت اورموند ستريت ذا هوسبيتال فور سيك تشيلدرن ان لندن. متشكرين جدا جدا دكتوره مريان على المحاضره ده اهي. واخيرا وليس اخرا يعني هنيجي التشالنجينج كيسز 10 دقائق اللي باقيين بقى باذن الله، وبعد كده البريك ربع ساعه على حسب اوامر الدكتوره مريان. الدكتوره ايمان محفوظ هتقدم لنا. نعم ما فيش محمد مين؟ ما فيش محمد. محمد عمر القمر رئيس جامعة حلوان. ما نقدرش نكسر كلامه. لا مؤتمر ضخم وجميل. إيمان محفوظة اتكلم لنا الأول عن challenging cases when the brain gets on fire. إيمان اتفضلي.